Hello, my name is Daniel Michalik. I am a core surgical trainee in the Wessex Deanery. Today I'm going to talk about this paper by Hudson et al., an evaluation of smoking as a modifying risk factor in chronic rhinosinusitis. This was published in JAMA Otolaryngology in December 2020. A bit of background. There's a relatively well-defined association between smoking and general respiratory health. However, the association between CRS and smoking is less well defined. This study aims to assess the prevalence of smoking amongst those with CRS and its associated symptom burden. This uses data from the CRES study, which ran from 2007 to 2013. It's a prospective, UK-based, questionnaire-based case control study and enrolled patients from 30 ENT outpatient departments across the UK. Crucially, all the cases that were included had CRS diagnosed by an otolaryngologist as per EPOS guidance. Healthy controls were generated from family members of patients or from healthcare staff. These were excluded if they had acute or chronic rhinosinusitis previously, or if they had another medical problem requiring a hospital visit within the past year. The questionnaire itself included socioeconomic and demographic factors. It included a question on smoking, as in how much they smoke on an average day. It included a SNOT-22 questionnaire, and also asked patients whether they'd had previous sinus surgery. They had over 1,500 responses, going down to 1,450 once missing or duplicate data had been excluded. As we can see at the bottom of this table here, there were 219 controls, and due to a limited number of those with allergic fungal rhinosinusitis, these were amalgamated with CRS with nasal polyps. Statistical analysis included a two-way t-test for the mean difference between SNOT scores between smokers and non-smokers in each group, and also a linear regression model to control for potential confounding factors in terms of age, sex, and asthma. So, what were the results? Well, as we can see here towards the right of the top table, the prevalence of smoking was higher in controls than either CRS group. Interestingly, the prevalence of asthma was higher among either CRS group than the control as well, and we'll have a little talk about that later on. If we move on to the second table, we can see that in both CRS groups, smokers had a higher mean SNOT score than non-smokers, and this is above the previously defined minimally clinically relevant difference of 8.9. As I said, they did a linear regression to control for age, sex, and asthma, and the difference in SNOT scores between smokers and non-smokers remained significant even with controlling for these. Interestingly, the non-smokers had more surgery than the smokers in the CRS groups, although this didn't reach a clinical significance. So, how valid are these results? Well, this is the largest UK epidemiological study in CRS, and it does benefit from a robust diagnosis of CRS compared to other studies which have used patient-reported diagnoses. This is supported by other studies using national data in other countries which have had similar results, in that they have not demonstrated a higher prevalence of smoking in the CRS population. There are some limitations to this study. The questionnaire generates limited data on smoking history, as in there's no data on whether patients had previously smoked, their pack year history, or second-hand smoke exposure, which all might be relevant. It also relies on self-reported data in terms of lifestyle factors, and again, this may add some inaccuracy. As the author alludes to in the paper, this is secondary care only and may miss some of the burden in primary care. The other question is, as there was a much higher prevalence of asthma in the CRS population studied here, how does that affect the prevalence of smoking in this group? Are those with asthma less likely to be an active smoker? The other question is how representative the control group is, as the prevalence of smoking in this group was 5% lower than the national average at the time of 20%. So, what's the take-home points here? Well, clearly the symptom burden in CRS is higher in those that smoke than those that don't, and as such cessation should be encouraged. Certainly as ENT surgeons, there are plenty of other reasons why we'd be encouraging our patients to quit smoking. This paper didn't demonstrate a high prevalence of active smokers in CRS, and further studies in future with a more detailed smoking history will be helpful to further determine the relationship here. This study didn't show any evidence that active smokers require more surgical intervention, and as such, active smoking shouldn't necessarily be seen as a barrier to surgical intervention. Thank you very much.